So I'm Sarah Vincent. I'm one of the stroke coordinators at the Corvallis Hospital. So you guys probably bring a few patients to us, but there's myself and Dan. So there's two stroke coordinators in Corvallis, and then Albany, we have one as well, Jody Andrews. Dan thought it was time to go to Hawaii, and Jody is going to try to have a baby tomorrow. So I'm on my own today. But I really appreciate you letting us come in and do some education. I feel like that's typically, so I used to work in the ER for about 7 years, so I do have a little bit of street cred. But then I decided I wanted to do something a little different for our family, and this position opened up. I really like it because code strokes, we respond, we get to have some patient interaction. And truthfully, that's our time to grab a hold of any of you, like Corvallis EMS, Albany EMS, and do education in the moment and try to talk through patients, because, you know, strokes are our expertise and you guys do everything else. So we found that doing face-to-face education like this is helpful, but in reality, the best time is like when you're in the moment, learning through the situation. So ideally, if we see you and we're talking to you, please just know that we're just trying to do some face-to-face education. It's and kind of just trying to dig deeper. And a lot of times, as you know, these situations are high pressure and we're trying to like quickly get information. Our goal today is to talk about strokes. So you're going to kind of get a quick down and dirty of strokes. And then we're going to talk about stroke assessments, the Cincinnati and the BEFAST. So the BEFAST would be new to you guys, newer, as I should say new to you as in it could be something that you guys are doing. Corvallis and Albany are adopting it. I've been talking to Dr. Sprague, who does like Lebanon area, and they're talking about doing this as well. And then also our new window of capturing patients, which if you guys have any feedback, I hope I'm not talking just to you guys today. I'm hoping that this is like questions, and there's no stupid questions, because I think that that just means you're listening and I can hopefully trigger a conversation from it. Oh, here we go. Okay, so I kind of talked about this. Why do we care? Basically, the biggest takeaway is that stroke used to be the third leading cause of death. But now that we're able to do a thrombolytic, so are any of you familiar with what our thrombolytic is? Or what it, I guess, what the thrombolytic does? So the whole goal of the thrombolytic is to eat away that blood clot. So we call it a blood clot buster. So if you hear me talking about a thrombolytic, that's the medication I'm talking about. And then are you guys familiar with a thrombectomy? Yeah, so the thrombectomy is the mechanical. So they're going to go through the groin, go up to the brain and pull the clot out. Samaritan does not do that. We don't have the capabilities to do that. But all 5 of our sites do have the capabilities to give a thrombolytic. So one thing that we do really monitor with our EMS process is just to make sure that anybody that might bypass a hospital, we just want to make sure that there was a reason why. A lot of times you get that phone call, like with Albany, they used to be down with their CT all the time. So they were on divert a lot. So people would have to bypass Albany to come to Corvallis. But now they have 2 CT scanners. So hopefully that's not the issue. But yeah, so those are one of our biggest things that we really monitor, is making sure that you're not bypassing your closest hospital. So Albany and Corvallis, we keep our stroke patients that receive that thrombolytic. So they'll get that blood clotting medication reducer, and then we keep them. But at the coasts and Lebanon, they call what we do as a drip and ship. So they get the medication and then they ship them to a higher level of acuity hospital. So instead of being third leading cause of death, it's now 5th leading cause of death. So we've done some improvement, but it's still the #1 leading cause of disability. Strokes are just, that's the bottom line, is if we don't get an intervention for these patients, we have to just physical rehab for them. And one statistic that's pretty amazing is almost 2 billion brain cells die on average every minute that you have a large vessel occlusion. Large vessel occlusion is a big blood clot. So when I say big, it's like the tip of your pencil big, but it's a big one to where we can do an intervention, ship them to do an intervention. Anything smaller than the large vessel occlusion, we just hope that the medication works, or we just have to have the patient recover. And also that, yes. Hey, good luck. Yeah.
Which hospitals can do that?
Good question. Riverbend, OHSU, Legacy, Providence, the bigger facilities are going to be doing the thrombectomies. Yeah. So there's basically two buckets of strokes. One bucket is your ischemic stroke. So that's the plumbing of your brain. You have a big hairball and you're not getting anything through. So something's stopping that blood flow. And then the other one we call hemorrhagic. That just means a head bleed. Have any of you responded to somebody who you suspected or was having a head bleed? They're pretty dramatic a lot of the times. What have you guys experienced?
I know had a gal, had a single episode, woke up, splitting headache. A family member was a primary care PA who broke aspirin, like full-size aspirin, was shoving it down her throat. And then she ended up going unconscious and vomiting, projectile vomiting. So I'm pretty sure that was true.
Whoa.
Yeah.
Okay. Multiple things on that one. That's interesting. Okay. Anybody else have feedback on a head bleed?
I had a patient who was about 300 pounds, was like losing their balance, and they ended up having a bleed in the backside of their head.
That's a really interesting one. Those are our difficult ones.
Yeah.
Because when you think of head bleeds, a lot of times you're like, boom, it's the worst headache of their life. They never have this headache. They're vomiting, they're nauseated, they're just miserable. And what we have seen and why we're trying to really bring attention to head bleeds is because we've seen the sense of emergency kind of slow down for them sometimes, and a lot of times they're not taken as a stroke. And so if you do suspect a head bleed, we would like stroke alert is really important on those patients. We've had patients sit in the hallway before and they went back to the room, and then all of a sudden the nurse was like, crap, this is a head bleed. We had to call a code stroke, get the patient to imaging staff, because in that case, you're basically going to be blood pressure control, hopefully symptomatic control at that point. If they have any swelling, or if you have to have a burr hole or craniotomy or something to open up a flap of your skull.
Why aren't they getting missed, do you think?
Because a lot of times they're not categorized as a stroke. They just think it's a head bleed, and that's not considered a stroke. I think it's just a recognition of a head bleed should be called as a stroke alert. That's what we've recognized. But yeah, and you think about how many headaches do you go out to? Migraines. So it's just kind of that instinct over the years that you guys have probably will gain or have gained, to where you're just like, nope, especially if they're saying this is new. I've never had this. It's the worst headache of my life. Yeah.
Potentially a stupid question. What's a good way to identify hemorrhagic strokes in a patient? Maybe like history, like have you fallen recently? Have you taken any drainage? Like, what's the best identification for that kind of injury?
I think that you kind of are geared towards that. Like, it's that same thing. It's the worst headache of your life. It's their symptoms that you're looking at. And then, if they say, oh, I get migraines all the time, this is kind of similar. Like, those are your kind of like your headaches, but with head bleeds. Yeah. Also, what's the blood pressure? If that blood pressure sky high, red flag, headache.
Intensity is like
Yeah, and they crump a lot of times fast. So these are patients that you could be intubating en route. Because if you think about it, you have a structure that doesn't move. The only place that the pressure goes is down, which is towards your brainstem, which your brainstem is basically the pole that your brain is on. And that's your autonomic nervous system. So that's how you breathe, your heart rate. So those are the patients that you might see respiratory rate going down, your heart rate going down. That's like when I start to pucker. I'm like, okay, we're in a red zone. But those are good questions. Good questions. And also, if you have somebody who has fallen, or you have somebody who's on blood thinners, that's definitely also concerning.
We can see anything different in the pupils.
You could, if it's severe enough. Yeah. Yeah, typically by that time, they're gonna be almost unresponsive. That's pretty late in the phase.
Okay.
So, welcome. So you have your brain tissue death, so that's the ischemic, and then you have your head bleeds. A lot of times you're gonna have patients say, I've had a stroke before, but it was a TIA. My little soapbox is TIAs are really not strokes. They are warning signs that they could be having a stroke. But if a patient comes in, they have symptoms and eventually they go away, we do imaging and it doesn't show anything on the imaging, that means that there's been no tissue death. So in order to diagnose a stroke, you have to have some sort of tissue damage in order for it to be a stroke. So TIAs are important, but I wouldn't consider them an actual stroke. Etiology, so what are you a high risk for strokes? And one of our biggest ones is AFib. So basically you have your heart kind of doing that fib flutter. If somebody's not diagnosed with AFib, the high likelihood of them throwing a clot is pretty high, especially what can be tricky is if they're a fib rate, fibrillation, and then all of a sudden they go into a normal sinus rhythm, all of a sudden your heart's pumping like it should, and those clots that kind of like formed are pushed out inside. And that's when you hear shower strokes. A lot of times that's from AFib, and those can be tricky too, because when you shower a clot, it can go both sides of your brain. So it can be tricky. So that's why we want them on blood thinners. And also, if you have a patient that was like, oh, I'm gonna go get I have a tooth extraction in a couple days. My provider told me to stop my Coumadin. So they stopped their Coumadin for a couple days. Well, now they're with stroke symptoms. So they're at high risk for having a stroke. I hate saying this word, atherosclerosis. Basically plaque in the vessels, right? So this is your high cholesterol patients. You know, carotids are your high risk. So your carotids are your big arteries in your neck. And that's a lot of times where we see that plaque buildup that's released and flicks off and it goes up into the brain. High blood pressure, that's basically, you guys know that one. It's a silent diagnosis that really takes a toll on people's blood vessels. That high blood pressure over time just makes their vessels friable. So eventually over time, either they can burst, so give yourself a head bleed, or something might just break off of the wall if it becomes hardened. Amyloid angiopathy. So this is a really interesting diagnosis. This is a head bleed type diagnosis. And I specifically remember a patient that we had. So we have a stroke support group outside of the hospital. So when patients are discharged, we meet with them once a month. And we had a guy that was diagnosed with this, and it was really just disheartening because he basically gets these random head bleeds, and there's nothing you can do about it. And just over time, he eventually just deteriorated. And it was really sad because he was really passionate about strokes and wanting to help the community. And every time that he came in, he just always thought it was so cool because he was our VIP patient and we would go see him. But that's a hard diagnosis to watch someone go through. And then of course, frequent flyer, drug patients, your cocaine, your meth. It's easy for me to say, yes, stroke is a high risk for them, but so is everything else. Cardiac arrest, internal infections. I used to do a lot of quality improvement for the emergency department. And so I would find cases for our director to review. And a lot of times, if there was any sort of history of drug use, I remember our ER doctor would always be like, you have to be checking them for everything. I mean, especially infections in the brain. I mean, it's just impressive of what can go wrong. Any other questions with that? Okay, so the easy part of this is, so this is the simple way to think of it. We like to do education with whoever wants to like kind of adopt us. And so we like to do education with elementary school. And so, because how many of those kids go home to their grandparents? So we do education with them. And the takeaway with this just is that, of course, if your head bleeds on the right, your symptoms are going to be on the left. So it's the opposing side. But it was really funny because she came to the to school the day after we did education, and she wore a ponytail on her right, and she tied her shirt on the left side. So she remembered about the stroke information. But if you do have a stroke on the right side, a lot of times it affects certain things versus the left. So if you have it on the right side, dysarthria, basically trouble speaking. You're going to have that kind of slurred speech type presentation. Left-sided sensation changes, left-sided neglect, and a right gaze preference. So I'm kind of contraindicating myself. So the eye, there's a certain place around your neck or the base of your skull where the nerves switch. And so sometimes your right eye can be affected compared to your left. So always here to complicate things. Left hemisphere speech problems. So this is what we call like expressive aphasia. So I'm having a hard time expressing what I want to say. And then also receptive. I'm not understanding what you're asking me to do, which how many times can you kind of chalk that up to confusion, right? So that's why some of the assessments we do in the hospital kind of focuses on trying to figure that out. And then like I was talking, brainstem issues. That's where you're going to have your nausea, vomiting, vertigo, dizziness, like you were saying with your patient. Speech, swallowing problems, abnormal movements, and LOC changes. So there's two different types of head bleeds, subarachnoid and intracerebral. So those are just different parts of the brain and I would say like where it's placed between the brain and the skull type head bleeds. Subarachnoid, worst headache of your life, light intolerance, stiff neck. That's a big concern as well. So if you have somebody with, there's another one, stiff neck. That would be another diagnostic. Intracerebral is your nausea, vomiting, headache, decreased LOC.
Why is there a stiff neck?
Pressure.
Oh.
Yeah. That's a good question. So so these are all of our mimics. So these are probably all patients that you're going to be dealing with as well. So stroke mimics that, are concerning: alcohol intoxication, cerebral infection. So basically your brain infections. This is where you're going to have infection, brain swelling. Do you guys, what would you say is the number one mimic out of all of that? I would guess what the number one mimic is for strokes.
Alcohol.
Okay. It's not it, but what other guess? Yeah. Yes. It's hypoglycemia. And that's when you do your call system, like when you call into the hospital, is that something that you're reporting to them?
Sure hope so.
Yes. That is the number one thing when we get patients in. I feel bad for our EMS sometimes. I'm just like, what's their blood sugar? And you guys get the blood sugar, we can take it and we can continue treating the patient. We don't have to take it ourselves. We have radiated people that should not have been radiated because of a low blood sugar. It's a strong mimic, but I do agree alcohol intoxication can be very, very hard to figure out as well. And Bell's palsy, I find that one difficult. If you guys go out to someone and your suspicion is it's Bell's palsy, still just call them a stroke alert. Just let the provider figure that one out, because you know the biggest difference between a stroke and Bell's palsy is you'll typically see the provider want them to lift their eyebrow, because there's nerves that go to your face that are being affected with Bell's palsy. And if you can't move your eyebrow or your face and you're not able to close your eye, then that's a huge sign that it's Bell's palsy. But what's difficult with that is that when the symptoms start, it doesn't necessarily, it's not in full effect right away. So you might just see somebody with a facial droop. And then as time goes on, it might affect the whole face. So just call them a code stroke. Have you guys ever heard of Todd's paralysis? I haven't encountered very many, but we have had a few patients where it's basically like they have a seizure and then they act like they've had a stroke right afterwards. There's not really, like I've researched it a little bit, and there's not really a reason to explain why this happens other than some sort of like part of the brain that's been affected and has slow neuron responses. But it could last a couple hours or a couple days. So again, even if you have someone that's had a seizure and they're acting like they've had a stroke alert.
We actually just had one of those, lady that we go to that has, when she had a seizure, she will be out of it for at least an hour, like not talking to you, eyes open, but just kind of like you're not even there. And I wasn't sure until we got a hold of family, and family was expressed as what she does when she has seizures. We took her in anyway, but I didn't think a stroke just because of the knowledge I had, but
Yeah,
don't see that very often. I've never seen, like, that's probably the only patient I've seen that just seriously just had a seizure and was that out of it for that long.
Yeah.
I mean, when I left her at the hospital, like, she could barely, like, she was trying to communicate with me a little bit, but you know, so I knew there was a little bit of change there, but it was still like she was able to talk to me. It was just like no. So
Yeah.
that was interesting.
but yeah, when you have those intense seizures, it's amazing how it's like just the body shuts down, or you have those post-ictal patients that are angry, confused. It can be really complicated.
Yeah, Austin had a comment for you, chief.
There you go. Austin Chan would like to know that.
Thanks for the complicated question.
He's good at that.
Again, so the biggest question I would ask the patient is this new? And if it's new and it has your stroke-like symptoms, such as your Cincinnati, then yes, I would be calling it a stroke alert. But if these are symptoms that they've had before and they just keep reoccurring and she has good days and bad days, I wouldn't expect a stroke alert.
Does everybody see the question? It was a patient in town has a brain tumor and it presents as a stroke. Do we call it or not?
Did that answer the question? Well, as you know, family members are great historians, but I understand too.
I think that's sarcasm.
They're
It
great
most definitely is,
historians
but
and they also can add a little some dynamics as well.
So Brendan, did it answer the question for you, Kat?
I think he was saying he didn't know what the question was.
Oh.
When you said it.
Yeah, Alex, I didn't hear or couldn't read what Champ's question was.
Okay. Did you want me to repeat it?
It sounded like Chief Herman Trent did.
We're good. then.
Okay. All right, yes, keep putting questions in the chat. Okay, so I'm sure the majority of you are familiar with the Cincinnati stroke scale. 3 main components: spatial droop, arm drift, and speech. So can someone like kind of give me an example? Like, do you guys literally assess this on them, or do you just kind of do your visual and kind of keep going and see if you see it along the way? Like, do you stop and have the patient put their arms out? Do you?
Yes.
Yeah. And when it comes to speech, do you guys have any tips or tricks that you find that are helpful to try to help dial in what kind of speech problems they're having?
I just try to have like a normal conversation with them, because I don't want them to overthink what they're saying and just based off their natural speech pattern. Are they actually able to say a complete clear sentence? Because they just say a normal sentence and it can be jargon. It's like, okay, that's definitely. But if you tell somebody to say a certain sentence, sometimes I feel like they try so hard to get it right that they say it more clearly than they actually probably would have said it if they didn't think about it.
Very valid point. Yes, because how many patients do we go out that are trying to like pseudo situations where they try to kind of mess things up purposefully, or they are thinking too hard to try to pass the test. Yeah, so trying to keep them in their normal environment and just asking them questions. That's a good way to do it. Because what are you looking for? Like with speech specifically, because that one can be tricky. That one can be multiple different things that you're looking at.
Are they missing words? Is it hard for them to remember how to say something? Can they identify an object in the room?
Yeah. Yeah, no, those are good ones. Yeah, because you're looking for slurred speech. You're looking for incomprehensible words. Is it appropriate to the conversation? Even just following commands, like I'll say, hey, Frank, can I have your phone? And instead you hand me your sunglasses. Like those type of things, that doesn't make sense to the conversation. He's not understanding what I'm asking him to do. There's mute. I don't know if you've experienced those patients where they just sit there and stare at you and like, you're like, I know you're trying so hard to give me the information, but they're just not able to get it out.
That was kind of my grandpa before he died.
Yeah, he had a stroke.
Yeah, he got a stroke on a Wednesday night and was gone on Sunday.
Severe stroke.
Yeah. Well, no one found him for like 12 hours.
Yeah. Sorry to hear about that.
Yeah, it happened back in 19. So.
Yeah, speech is really tough because you know that they're trying to say something, but they can't quite get it out. Arm drift, that one, the only way to do it is just to have them put their arms out, close their eyes. Today I thought it was really interesting. I had a patient having their arms up, and I always learn a little something because we have, I don't know, are you guys familiar with our Beeman or our robot that we have at the hospital? So we don't have, like, shockingly, we don't have neurologists in the Samaritan system. And this is a nationwide issue. Corvallis Clinic has neurology, but they have their own community, and to where they were unable to support inpatient and outpatient. So they're only doing outpatient neurology. And a lot of neurologists, as like a lot of cardiologists, specialize. So these neurologists specialize in like chronic issues, not necessarily just stroke. And then if they do, if they're limited. So how do we help with that is we have our contract with Providence, So whenever we have an acute stroke, so you guys give us a stroke alert patient, rush them in there, we are automatically calling Providence saying, hey, we have a possible stroke. They're looking at images as we are rolling the patient through the imaging process. When we get back to the room, I would say within like 10 minutes, they're beaming on to that robot and they're assessing the patient. So they're doing a neuro assessment on that patient. And so that's what happened today. So the patient came in, was having symptoms, but one thing I noticed that the provider did was when he had him put the arms out, he said to close your eyes, but he made him put them closer together. And I'm not quite sure if that had to do something with like coordination, which is kind of like a tidbit. He really wanted them to have them close together. So I think that that kind of maybe made a little difference with like muscle control and coordination. So but yeah, so we're really thankful to have them because otherwise we have ED providers practicing stroke neurology. And so we're able to provide that. Okay. We do, so there's an NIHSS, and that's basically a 20 to 25 question assessment that nurses do and providers do in the hospital. So that's where you might hear the patient with a piece of paper in front of them, and we might ask them what pictures they're looking at. One of them is we'll have a picture and it has like a mom at the sink and it's overflowing water and there's kids in the background and one of the kids is falling off the chair. And so we have them describe what's going on in the scenario just to see if they know how to express what they're receiving. It's a really thorough assessment and takes like 15 minutes to do. Okay, so this, I don't expect you guys to memorize. I think the biggest takeaway is these are all different assessments that EMS can do outside of the hospital for stroke patients. To me, what this means is we can't capture strokes with one assessment. So do your best. This is where sometimes clinical judgment has to come into play. This is why you're doing what you're doing. Again, relying on that instinct also. Like, you know, I would prefer you guys to call a stroke alert than not. In all honesty, a stroke alert is much different than a code 99. A code 99, if you get there, you might have 20 people at your bedside. With a stroke alert and within Samaritan, it's basically an alert, and we just are telling pharmacy, hey, we might have a patient, imaging, we're coming in hot, house supervisor, ED provider, we want you meeting us at ambulance bay. So it's more of a communication piece. So if you guys call it and the provider doesn't fully agree or wants to assess the patient, they may not call it overhead. They'll wait for you to get there and assess the patient first. So don't hesitate to call stroke alert. And also these are LVO assessments. So again, like I said, large vessel occlusions, and your large vessel occlusions assessments are more important in the areas where you have to figure out which hospital to go to if you have like 2 or 3 that are really close. And so with Samaritan, we only have thrombolytic sites. So you guys don't have to choose between, oh, we need an LVO site versus just a thrombolytic site. So we don't teach to the LVOs so much. Do you guys want to take a little break, stand up? I feel like a lot of you are starting to get tired. Or feel free to stand up and stretch if you need to. Okay, so this is the BEFAST tool that we are proposing to be used. This is a tool that we have not only our triage nurses doing, this is the tool that we use out in the community, and this is the tool that stroke coordinators were using. And the reason we like it is because it's rapid, it's fast, it's kind of, you know, it's a more simplified. The fast, so we're not adding a ton to this assessment. The fast portion of it, so the FAST portion of it is basically kind of what you're doing now. but it's the B and E portion that we're trying to capture. And those are your like atypical stroke symptoms. So like you were talking about the cerebellar stroke, the head bleed, and the symptom was dizziness, like those are the ones that we have a really hard time capturing. And those are the ones that get missed so much. So B stands for balance. Are they having gait issues? Are they wobbly? Sometimes your patients can't stand, so have them sit, and while they're sitting, have them put their arms across their chest, and are they able to hold themselves up? We might call it truncal ataxia, which just basically means they're not coordinated with their trunk. They're not able to hold themselves up. Are they listing to one side? Those are all things that when you bring a patient to the hospital are really important. We just had a patient today where the patient came in through triage and he was complaining of right-sided weakness. He was outside doing some yard work and it suddenly happened. Came into the ER, and when he went from his car to the triage, he was able to walk. And so before that, he wasn't. And so just those type of communication pieces are really helpful to us, because how, so many times when they're brought in by EMS, we go stretcher to stretcher. We don't always ambulate the patient. So if you're able to witness any of that, it's really helpful. Dizziness is part of this assessment. Dizziness, you guys will be seeing a lot of patients on. The key components when it comes to stroke is a sudden onset of dizziness and having them define their dizziness. So if someone tells you dizzy, it's going to be a red flag in the sense of like, I need to define this and I need to figure out if there's any other symptoms. When it comes to like slurred speech or facial droop, those are just kind of like, probably a stroke. But when it comes to dizziness, it's like, is this lightheadedness? So is it like with changing of positions? Is that more of an orthostatic type thing where they could be dehydrated versus dizzy to where they stand up and they just can't hold themselves up, or maybe they're feeling dizzy because they're weak on one side. Maybe they're feeling dizzy because they're running into the wall because they can't see. So just kind of trying to define that term, but also the majority of the time when it comes to a stroke and the patient's dizzy, there is going to probably be another symptom within this tool. And so that's why I say when you have a dizzy patient, you might need to kind of dig a little deeper. And I know that you guys are limited with time, but I also know how talented you guys are at quickly assessing patients. And as you're packaging them up, you're able to do things. E is for vision. Sudden onset of blurred vision. Again, is this a new symptom for that patient? Blurred vision, double vision. Are they noticing their peripheral? So if someone stands up and you say, can you sit on the cot? And they're like, well, what cot? They can't see it. That's obviously, a concern. What's your name? Stuart. So let's say I'm assessing Stuart and I'm talking to him. I'm going to purposefully go to one side and see if he's tracking me. And then I'm going to also try to go to the other side to see if he's following me as well. Like that's just a simple way of like, I've noticed he's tracking me. And so if you see someone and all of a sudden I go to the opposite side and they stop tracking you and they stay midline, that's a huge concern. The person doesn't see possibly past the midline. F is for facial droop. A is for arm. So we talked about that one already, that drift. One other one that I always like to do is just a grip. Do a real quick grip squeeze of the hands, because that's what you hear too with patients is they'll be like, I was drinking my coffee and I spilled it because I just couldn't quite have that dexterity to hold on to the cup. And of course, if your arm's involved, the likelihood of your leg being involved is very high as well. So it's that one-sided typical stroke symptom. S is for speech, which we already kind of went through. They have added a T for terrible headache. And again, that's going back to that head bleed about these patients. We're not talking about the chronic migraine patient. We're not talking about someone who just takes Tylenol and Advil every now and then, and they're just having a subtle headache. We're talking about that patient with that sudden onset, worse headache. Sometimes you hear patients say that they get a big clap and then have that instant headache. And then another one of my soapboxes I have is if you're able to get a clock time on the patient's last known well. That's really vital. If you can't, you can't, like, but just if you can try, it's really, really helpful. When they come to the hospital, sometimes I will spend 20 minutes trying to find out, you know, I'm calling the nursing facility, I'm calling family, I'm calling the brother, the sister. It can be grueling to try to figure it out. But I guess the reason I'm saying that is because that's how important it is to us to try to find that last known well. If the patient wakes up and they have the symptoms, what time did they go to bed? That's the time that we need. If the patient wakes up and they're completely normal, and then all of a sudden they were making breakfast and they fall to the ground because all of a sudden they lose weakness in their right leg, what time did that happen? And then also family. We want family in the room with that patient. Do you guys let family write with you? Yeah.
We'll get back there.
Well, if not, it's not like, I'm just saying, if they can come with you, that would be great, or just tell them, just follow you in. I've had to assess patients in the room, and then I've had to run to the parking lot to talk to family to try to figure out if this is normal for the patient or not, and I know that we've missed strokes because of this. And so we've highly advocated for our stroke patients that they need someone in there, because the likelihood of them not knowing what's going on is very high. We get patients that come in from car accidents because they felt like they were having a stroke, so they brought themselves in. Well, they didn't realize their whole right peripheral vision is gone, and they get in car accidents. So,
We suspect that my dad had a stroke and what caused him to break his shoulder.
oh, really? From a car accident?
No,
Oh.
he just, it was medication he was taking at one point. Caused him to have a stroke, he fell, and so all the focus was on the shoulder that was now broken.
Yeah. That happens. We get tunnel vision. You need to make sure you have your numbers under control. Your grandpa and your dad with a stroke?
Yeah.
Sorry.
Also have a
That
friend who
was-
had a stroke too.
You can have them for a full hour after class, actually.
They're just handing you off. Okay, so have any of you heard how we have changed our criteria on calling code strokes from 6-hour window to 24-hour window?
Yeah, I think that might be helpful. You said we a few times, we've changed things. Is that a Samaritan thing, or is that an American Stroke
Is
Association?
that Samaritan thing?
Just a Samaritan thing?
Yes.
And what's that coming from? Is that coming from your guys' research, or is that coming from somewhere else?
That's coming from our research, is coming from Providence.
Okay.
They kind of, so we use them a lot for our expertise because we don't have neurologists. So we have a close relationship with Dr. Bob, which is one of their neurologists. The biggest reason is because we miss those large vessel occlusions, and those patients are still emergent, and we need to get those patients through our system. And so that's where that 24-hour window comes from, is because they can do thrombectomies up to 24 hours. So these patients that are having these major strokes, and it's, you know, they wake up with these symptoms, they still have a window of getting that intervention, of getting that clot retrieval. So when I say we, I'm meeting Samaritan, and it's something that our triage nurses are doing, and I think Corvallis, Albany, and maybe Lebanon are adopting. But it's kind of slowly going throughout the system. But you guys have not started the conversation, the 24-hour window
No.
with your program. Okay.
Salem Health, their neurologist in-house, isn't it? I don't expect you to know, but maybe you do.
I don't know.
Okay.
I know that they're not thrombectomy. And I know that their stroke program's pretty newish, like the last year or two.
I'll do you question.
And then, okay, this is one of my favorite pictures. This is another reason we do what we do, and this is such a nerdy term, but it's save the penumbra. That's our goal as stroke coordinators, as healthcare system. The black dot is basically your stroke. That is the damage that's already been done. There's nothing we can do about that at this point. But our goal is to save the penumbra, which is the outskirts of that tissue. It's what they call salvageable tissue. So if we're able to get that blood flow back in there, we're going to be saving a lot of patients' brain monopoly. Like that's a lot of property that stroke could be taking up. So at the very top, you can see the infarction, which is the dead tissue. And let's say we saved it. There's still some, it's still gotten bigger, but not as big as it could have been. So that's the goal. So I don't think Salem has changed to tenecteplase for their thrombolytic. I think they use alteplase still. Samaritan has transitioned to tenecteplase. And the really cool part about that is that instead of doing it in, have you guys had to transfer patients on tenecteplase or alteplase? No. Okay. Because it's kind of annoying on your part because it's a drip. And then once the drip's done, you have to put a normal saline flush to like make sure the medication infuses through the whole tubing. And so with tenecteplase, we're able to give a 5-second bolus and then we're done. So if we have to transfer these patients, they're not attached to anything, which is really nice. The reason we transferred over is because it had a superiority over alteplase for large vessel occlusion. So it had it has a higher likelihood of opening up that blood vessel with the large vessel occlusions versus alteplase. Since we don't do thrombectomies, we felt like that was probably the best choice for our patients, because if a patient does have a large vessel occlusion, our goal is to get them in and out of our hospital within 2 hours. That's still 2 hours of tissue death that's going on. So if we can open that blood vessel and get them up to Portland, that's the best. Endovascular therapy, that's the thrombectomy. Like I was saying, they go through the groin, they go up to your brain. It's that simple. And they just pull it out. It's not. But it is something that we don't do. Riverbend, Providence, OHSU, Legacy, they all are able to do that. And typically these patients will probably not be in your hands. We're probably going to life flight them. So we're just trying to get them the heck out of our facility and get them up to intervention. Any questions on that?
How often do you find that weather stops life flight from flying for you?
A good chunk, especially during winter. The coast sites, I think, have the hardest time with that population. And then even with ground transportation at the coast, it's harder. But yeah, it's very dependent.
I have a quick question.
Yeah.
On the medication, why does that need to be given within that 3 to 4.5 hour window?
That's a really good question. So 0 to 3 hour window, the population that we can give that medication to is we can give it to a 90-year-old in that window. But once you get beyond that 3 hours, your blood vessels become friable. And so that your blood vessels have an increased chance the longer it's been without blood flow of having a head bleed after you get the medication. So if you're beyond the 4.5 hour window, they deem it unsafe to give the medication because you have a higher chance of having a head bleed because the tissue and the blood vessels are really fragile at that point. So why couldn't you get the medication? People that have had severe head trauma, the jarring, the shearing, all of that. Who knows what blood vessels have been jolted to where you'd be a high risk for a head bleed. Any internal bleeding that you've had, if you've had a head bleed before, if you've had a recent GI bleeding, you know, we're going to be changing your clotting times, and therefore you're going to have a high risk of bleed anywhere else internally.
What's heparin?
Heparin?
Yeah.
Not from a year.
Okay. Heparin is another medication that they use in the hospital that helps with like blood clots. So if you're going to be at the hospital for a lengthy period of time and they're worried, well, I would say majority of patients get some sort of like sub-Q heparin because they don't want them to form any blood clots while they're sedentary or while they're in bed all the time. So if they're getting that medication, they can't get another type of blood thinner. And then I think our last topic is just really quick, hemorrhagic strokes. Like we've kind of said, they're a high mortality population. What can we do for this population? Reverse the bleeding. So if they're on Coumadin, we need to reverse the Coumadin. If they're on Xarelto or Pradaxa, we need to try to reverse that. The next step is coiling or clipping, which is kind of an aneurysm type thing. So are you guys familiar with aneurysms? Yeah, I mean, aneurysm, what's that?
It's a bad thing.
It's a bad thing. Yeah, it is. Like aneurysms can be in any part of your blood vessels. But if they're in your brain, it causes a stroke. So if they see a aneurysm, it's kind of like a bulge. Maybe it hasn't burst yet, but it's causing enough pressure that's causing issue. They can go in there and put like a coil to clot it off and stop it. Or they'll go in there and clamp it. We don't do that at Samaritan either. Those patients would be shipped. We basically take your skull off to release the pressure. So we're going to be doing blood pressure control, reverse the bleeding, and symptom control. So we have to intubate this patient, release the pressure, anything like that. One other thing that I would like to make sure to really take away home is that, have you ever heard of like an anticoagulation? Like if one of your patients is anticoagulated, you know, what kind of medication that would be? Do you guys have any examples? I think I've said it once or twice.
What blood thinners do we worry about? Is that what you're asking?
Yeah. Yeah, what blood thinners do you worry about?
Yeah, good.
Yep. So if a patient tells you they're on Coumadin, and then there's the other category as Pradaxa, Xarelto, Eliquis, those are also red flags, but those are not to stop the patient from getting a thrombolytic. So we will have to figure out what their INR is. So what's their blood work show? Because if it's subtherapeutic, they could still get the medication. If they didn't take their Eliquis for 2 days, they could get the thrombolytic. So don't let the blood thinners stop you from bringing the patient in or calling a stroke alert.
But what you're saying is an accurate medication list.
Yes. If you're doing a stroke alert, that should be one of your first questions. Are you on any blood thinners? Someone's probably going to say, oh yeah, I'm on Plavix or aspirin. Those are what I consider the puppies. Those are like the little ones. The big dogs are the Coumadin, the Xarelto, Pradaxa. Those are the ones that are going to make a huge difference. Those are the ones that you're going to be seeing on your AFib patients, somebody that might have a clotting issue, PE, like pulmonary emboli. Those are the big drugs that you're going to see with those patients. Plavix and aspirin, that doesn't have much hold with the thrombolytic.
And you guys just do PTINRs to figure out your time frame as far as it's taking order?
Specific to Coumadin. With the other ones, we can't do any blood work. So that's why we have to go off of, how long has it been? So if it's been 24 hours, they probably can't get the medication. But if it's been longer than 48 hours, then they can't. I did have a guy come into Albany and he had stroke symptoms, and I was like, okay, we're gonna be giving some thrombolytic. This guy's having a stroke. And as we were talking, he was like, I'm going in for a procedure. They told me to stop taking my Xarelto. I stopped it. And then he started getting these symptoms. And he goes, at the very end of our conversation, he goes, I was scared I was having a stroke, so I took my Xarelto right before he came in. And so I did not even have the heart to tell him at that point that took him out of the candidacy to get the thrombolytic, but it did. So that's another thing is don't give them medication. Don't crush up aspirin and shove it down somebody, especially with a head bleed. You don't want them to have any more blood thinners. So and we tell the community if they think they're having a stroke to call you guys. You guys give us that heads up. We prepare our team, to do it. And we're able to shave time when you guys bring them in. Typically, you guys have vitals. Typically, you guys have the history, IV. Some places are trying to get blood work beforehand and hand it off. It's a stroke alert. But it's very helpful. It's about a 15-minute, 20-minute difference between triage and EMS. And so with our triage process at Samaritan, we're mirroring that of you guys. So we don't even take them to a room. We take them to a place in a hallway. We don't get them undressed. We don't do vitals. We do a blood sugar, and we don't even do an IV. We just take them straight to imaging. Once the first head CT is done, then we take them and put an IV, draw the blood, and then we do the CTA. So we try to make it quick. We try to mirror you guys.
You expect that you're gonna get more stroke alerts now with this new inclusion criteria? Is that the goal?
We have gotten, we went from about 20 to 30 code strokes in Corvallis, and now we're to 40, 45 the last few months. And again, we've had multiple conversations with Providence as well, and they were like, well, we expect double, if not triple.
So they're happy with the volume.
What's that?
Except for milk.
Mhm. So these are patients that you're already seeing. It's just code 1 versus code 3. Another thing to just kind of let you guys know, when you guys bring your patients in, our goal is to get them to imaging as fast as possible. So some places won't even have you take them off the gurney, and they'll have you go straight to imaging. Have you guys experienced that?
Yeah.
No?
I have. Live for balance.
I was gonna say, only.
Okay, well, that's what I mean. I think that Salem definitely, just this last few years, they just got a stroke coordinator, I think. And I think they're really trying to improve their process. So be prepared for that. Like that's, kind of, it's a little oldish, but that's kind of what they're doing now is we're just taking them straight to imaging. And so if you come to the ambulance, we'll have you go straight to imaging. Our goal is to get them to CT, and CT is going to tell us, do they have a head bleed? Do they have an old stroke? So those are the only things that our CT is going to tell us. After that, when we put the IV in, it's going to tell us, the CTA is going to be like, okay, do we have a large vessel occlusion or don't we? So is this going to be one that we're going to medicate and ship or not? And even after that, if those 2 images are still negative, we still treat stroke patients. We don't know if they're having a stroke or not. And the only way to know if they're having a stroke is if they did an MRI, because that shows the tissue that's died. So we do a CT, CTA to just see where it's going to direct us. And then it's a clinical decision at that point. And that's why Providence is really helpful with us to help us decipher some of these neurological deficits.
How long do these all these imaging techniques, how long do they take if you're just scanning the head?
The first CT one takes like 3 minutes.
3 minutes.
Yep, and then the CTA, once you get the IV in there, it's about 5 minutes.
Do you always do an MRI after that, or just depends?
It's, so we do an MRI if the patient's admitted.
Oh, okay.
That's when we'll do the MRI. So a lot of times we admit patients, we think we're pretty positive it's a stroke. We've treated the patient with tenecteplase, and then 24 hours later, we'll do a MRI, and then that tells us where it's at, if it was a stroke.
That happens 24 hours later.
With that,
The MRI happens 24 hours later.
to make things complicated, we can do a fast MRI for our stroke patients, which is more on the rare side, but we do it for our younger patients a lot of times. So like if you have a 40-year-old ish patient come in and they're having stroke-like symptoms, and we did the CT, CTA, they're still negative, but maybe it's a dizzy patient, and we're like, the only symptom we have is dizziness, you know, and so we're like, let's just get this fast MRI, and if they're having a stroke, we'll treat them. Otherwise, we wouldn't treat them. So.
Is the reason for the 24-hour delay just because of the difficulty of performing an MRI, or is it because there's no real risk benefit once you're treating them, or?
So when I said 24-hour, that's typically post thrombolytic.
Okay.
So once they get the tenecteplase, we do a 24-hour because we want to make sure they didn't have any sort of head bleed. Because if that 24-hour MRI is there's no head bleed, then we'll give them medication like an antiplatelet, like aspirin or Plavix or something. So that's kind of like the standard of care post-stroke. But if a patient is admitted to the hospital and the next morning they have it ordered for an MRI, it could be 10, 12 hours later. There's no time frame when it's just a regular stroke without the medication. It's complicated. I think the biggest takeaway is don't hesitate to call a stroke alert. You know, all you're interrupting is the nurses and the provider. I mean, that's important. There are times important, but they're the experts that can kind of help figure this stuff out. Any questions?
Does anybody online have any questions for Sarah?
I do. I'm sorry if this is already covered. I just stepped out for a minute. But so with blood thinners, I've heard that you want to know what blood thinner they took and at what time, right? Is there anything else to that, or?
I think if you can just tell us blood thinners, if it's Coumadin, Pradaxa, Eliquis, Xarelto, I think if you could just at least know that,
Does
that's
the
helpful.
dose matter, or do you just want to know the name of it?
Don't worry about the dose. Yeah. Just to know the name of it. Of course, it'd be great if we knew the last time they took it, but we can figure that out. So that's why you just tell family to come with them. I would prefer you spend more time on the last known well than dose or timing of the anticoagulant.
What would you say is the average age of someone having a stroke, and do you see it fluctuating?
Good golly, I would say the last year or two, they've gotten younger. I mean, we see 50, 60-year-olds having them more and more. Of course, 70, 80s, 90s is your higher patient population. But we're seeing them younger and younger.
So if someone has high blood pressure, at what point should we be trying to control that? Because I've heard you should just let it be, or you should try to drop it. What's the current?
Really,
school of
really
thought?
good question. So somebody that's having a stroke, there's not much with blood pressure control that I would be too worried about unless you have a head bleed. Are you guys gonna know how to do that out in the field? No. I don't, do you guys have protocols for blood pressure control?
We have a bit along.
Do we area?
So I would say, if you are thinking that you might need to give a medication like labetalol for a stroke patient, do you guys call the ER to ask for recommendations, or is that just something that you would give on your own?
Well, we have a hypertensive crisis protocol, so we might get on our own.
Okay, so if you're thinking, so one takeaway is ischemic strokes are typically not painful. So if you have someone that you think is a head bleed and their blood pressure is 180 over 110, I'd probably give them a whiff of labetalol. A whiff.
With, okay.
But if you have an ischemic stroke, I wouldn't touch their blood pressure. Because if you drop it too much, you can extend their stroke.
So if it's an ischemic stroke, you don't want to drop it, but if it's a head bleed, it would be preferable to drop it. If there is a way to know.
Exactly. But I mean, those are your patients that are gonna be excruciating head pain, vomiting, blood pressure is gonna be 220 over 120. Like they're gonna have a high blood pressure typically. Like those are patients that I would feel comfortable giving some labetalol to. But if you have someone that's just having a stroke and there's no headache and no like massive pressure in their head, then I would just let the blood pressure ride. And that's what we call permissive high blood pressure. In the hospital, they'll let people's blood pressure go 220 over like 150. If we drop it, what happens is you drop somebody that is so used to a high blood pressure, and then you drop it, it stops perfusing like it normally does. And that tissue, you can extend the stroke because it's not getting blood to that tissue.
So we should leave the blood pressure alone. If we think we need to give something, then we should probably call it.
And I would just look at our protocols, Alex. That's where Dr. Lucas puts that as a precaution. So
Is the precaution as,
you can do it, but you better have a good reason as to why. So
yeah.
I would call them. But I think it's a good thought.
It really, no, that's a good, it's weird because there's people that are in the hospital where their blood pressure skyrocket. And I'm just like, can we please do something? But it's no, don't. We have patients that will, their symptoms will go away and then we'll have them stand up and all of a sudden they come back because they're not able, there's a perfusion, they're not able to get all their blood flow. So we'll lay them flat, then all of a sudden the symptoms go away again. So we're pumping them with fluid and making them lay flat. Yeah. Questions? Anybody else with those? I like them. Okay. Well, thanks for having me.
Yeah, thank you.
Yeah.
Stop the recording.
Okay. And if you guys do decide doing any sort of BEFAST or anything, let us know.